In the previous videos, we have discussed extensively on the anatomy, embryology, and the physiology of thyroid glands. In this particular section, we are going to discuss entirely on the clinical part, that is on the workup and the diagnosis of thyroid disorders. We have a lot of investigations in our kitty, but how you use them really matters. So please do go through this video carefully because you're going to understand and correlate a lot of things in this particular video. And this is also going to form the base of your future understanding about may it be a thyroid cancer or may it be a functioning problem like a hypo or a hyperthyroidism. So be careful. So I'm going to group the different types of investigations into various categories so that you can understand them in a better way. So let us take the different categories first. The first category I'm going to discuss is on the thyroid and the related hormones group. So we have a lot of other things like antibodies, ultrasound, FNAC, a lot of things. So first I'm going to discuss on the thyroid and the related hormones. So thyroid and the related hormones, in the sense, you are going to use two important investigations in this. One is going to be the TSH and second one is going to be the thyroid hormones T3 and T4 itself. So in that, let us see what is going to be the importance of TSH. So let us know the physiology of the TSH first. So you know the TSH is going to be released from the pituitary gland in response to TRH that is coming from the hypothalamus. This TSH is going to stimulate the thyroid gland because the thyroid gland and the follicular epithelial cells of the thyroid gland is going to have this TSH receptor. When TSH binds to the TSH receptor, which is a form of G protein coupled receptor, especially the G stimulatory type of G protein coupled receptor, and they're going to increase the cyclic AMP, and by virtue of it, they are going to produce a lot of effects on the thyroid gland. So what are the effects? The first effect is the trophic effect. Remember, TSH is a trophic hormone, definitely, which means they are going to increase the vascularity of the gland. At the same time, they try to increase the size of the gland as well. At the same time, this TSH is going to stimulate various molecular level pathways in the thyroid gland. So what are the molecular level pathways that are stimulated? Obviously, they are going to stimulate the sodium iodide symporter. Very, very important. Remember, by far, one of the most powerful stimulators of the sodium iodide symporter is the TSH. There is no other powerful stimulator than this TSH than for the sodium iodide symporter. Very, very important point, which means TSH is one of the agents that strongly stimulates the iodide uptake by the thyroid gland. Very, very important point. Next, they also stimulate the TPO enzyme, which means they are going to increase the synthesis of the thyroid hormones. At the same time, they also stimulate the endocytosis of thyroglobulin molecules, which means they are also stimulating the release of the thyroid hormones as well. Endocytosis of thyroglobulin molecules, which means they can even increase the release of this thyroid hormones. So this is the molecular level mechanisms, how TSH works and stimulates the gland. What is the normal values of TSH? Again, it varies according to laboratory. Some laboratory gives 0.5 to 5, some laboratory gives 0.5 to 4.5, some laboratory gives 0.5 to 5.5. But remember, the American Association of Clinical Endocrinologists give a value of 0.5 to 4.12 as the normal range. This is the AAC definition of normal TSH. Clear? So what are the advantages of TSH? So what are the uses of TSH? Where are the places where you're going to use this TSH? Remember, TSH can be used for diagnostic purposes. TSH can be used for monitoring therapies also. For diagnosis, it is considered as the single best investigation for diagnosing primary hyper as well as hypothyroidism. For primary hyper and hypothyroidism, this TSH is considered as a single best investigation of choice. But please note that it can be inaccurate in the diagnosis of secondary or central hyper and hypothyroid disorders. For secondary disorders, TSH is not accurate. You have to have a correlation of different values, including T3 and T4. But for primary, yes, single best. And similarly, it is the first investigation that is performed in a patient with a suspected thyroid nodule. Multiple times asked questions. The first investigation to be performed. If they ask you in a thyroid nodule, investigation of choice, it's FNAC. I'm not denying that, but for the first investigation is always going to be your TFT or TSH in particular. For monitoring treatment, again you can use TSH. Remember, the single best monitoring tool for monitoring treatment when the patient is on primary hypothyroidism. For monitoring treatment in a patient with primary hypothyroidism, this is going to be the single best investigation. But for monitoring treatment in primary hyperthyroidism, TSH is not that beneficial, where we use the T4 and the T3. That's actually more important in primary hyperthyroidism, like Graves' disease. But for primary hypothyroidism, TSH is the single best investigation for monitoring therapy with levothyroxine. If they ask you the single best investigation in a thyroid function test, again answer will be TSH only. Clear? So what about the T3 and T4? T3 and T4 are of two types. One, you can measure the total T3 and T4. Second one, you can measure the free T3 and T4. Free T3 and T4 is the one that is preferred, and almost all of the non-pregnant population are going to be tested for this free T3 and T4 preferably. At the same time, remember, this free T3 and T4 are the ones that are going to reflect the physiological and active forms of the thyroid hormones. Whereas total T3 and T4 is going to reflect both active as well as inactive forms or bound forms, free forms as well as bound forms. Both this, when you add together, you will get the total T3 and T4. The problem with this total T3 and T4, it's strongly influenced by the TBG levels, thyroid binding globulin levels. Conditions that increase the TBG will increase the total T3 and T4. Conditions that will reduce the TBG will also reduce the total T3 and T4. But still, even though, because of a lot of trial data are telling that in pregnant women, this total T3 and T4 is the one that is preferred due to various reasons that is not even understood right now. But total T3 and T4 are the one that is preferred in a pregnant women and pregnant population. Clear? So now you know the different thyroid function tests or the thyroid hormone related tests that you're going to use, and let us plot the T4 or T3 and the TSH and find out what is the interpretation. TSH is normal, T4 is also normal, which means usually it becomes a normal person. But remember, in this condition, if the T3 is decreased, suppose if T3 is decreased in the presence of normal TSH and T4, think about a non-thyroid illness or a low T3 syndrome. If you have a higher T3, very rare, but think about isolated T3 toxicosis. Very rare entity, but you can remember nevertheless. Isolated T3 toxicosis, this can happen in early forms of primary hyperthyroidism. Then, what if TSH is increased and T4 is normal? So this condition is a subclinical hypothyroidism. This is subclinical hypothyroidism. Why it will come under subclinical hypothyroidism? We have a common rule, isn't it? We know that fact. Whenever you have a thyroid gland and you have a pituitary, so now if you have a low T4, which is a primary problem, which is a thyroid problem, because of some thyroid problem you are having a low T4, and that will obviously stimulate the pituitary gland to produce excessive TSH. Now this excessive TSH is stimulating the gland, and this excessive TSH is needed to normalize the T4, which means that excessive TSH has normalized the T4, which means the gland should be continuously stimulated by that excess TSH to produce normal amount of T4, means itself it's a hypothyroid state only. So subclinical hypothyroidism itself is a state of primary hypothyroidism only, but the patient is not manifesting clinically, probably, but they can manifest. But ideally, the idea of calling this subclinical is the patient is not going to manifest clinically because of the normal T4, but the TSH will be elevated, suggesting that the gland is not appropriately responding to this high TSH, and they still produce only normal amount of T4. Okay. Suppose if you are having elevated TSH with a low T4, this is often referred to as a overt hypothyroidism. Here there is no doubt at all. Here there is low T4 despite having high TSH means the thyroid gland is not responding. That is a primary hypothyroidism, overt primary hypothyroidism. Then if the TSH is low and the T4 is also low, definitely this is a secondary hypothyroidism or a central hypothyroidism. Here the reason is T4 is low because the TSH is low. So then if the T4 is low but the TSH is normal, again this indicates a secondary or a central hypothyroidism only. Very important point, because you know this low T4 is a very, very powerful stimulator of thyroid gland, pituitary gland. But if this low T4 is stimulating the pituitary gland, but still they produce only normal amount of TSH, means the problem is in the pituitary only, not in the thyroid gland, because the TSH coming from the pituitary is not adequate to produce a normal amount of T4. So that's again taken as a secondary or a central hypothyroidism only. Suppose the patient is having normal amount of T4 but a suppressed TSH, obviously this will come under a subclinical hyperthyroidism. Subclinical hyperthyroidism, it is a form of primary hyperthyroidism only. If the TSH is low and the T4 is high, definitely this patient will be having a overt primary hyperthyroidism. And similarly, if the patient is having a high TSH with a high T4, I can tell this patient is having a secondary or a central hyperthyroidism. At the same time, if the patient is having high T4 with a normal TSH, again I can tell the patient will be suffering from secondary or a central hyperthyroidism. The idea is very simple. Here the T4 is high, but still it is unable to suppress the TSH. High T4 should suppress the TSH, but if it's unable to suppress the TSH, definitely the pituitary is the problem, secreting high amounts of TSH rather than necessary. That's why the T4 is high. So definitely it is a secondary or a central hyperthyroidism only. So these are the interpretation of the different thyroid function tests based on the T3 and the T4, TSH. Clear? So we have discussed everything regarding the T4 and the TSH in this particular entity. So now let us move on to the next diagnostic, that is going to be on the antibody assays. So what are the antibodies that you can use? The first antibody I can use is anti-TPO antibody, otherwise referred to as anti-microsomal antibodies. Second, anti-thyroglobulin antibodies, which is not at all performed commonly. And the third one is TSH receptor antibodies, otherwise referred to as TRABs, or thyrotropin receptor antibodies, or TSH receptor antibodies called as TRABs. Remember, this anti-TPO and thyroglobulin antibodies are relatively non-specific. They can be seen in many conditions like Hashimoto's thyroiditis and other condition that produces painless thyroiditis, not painful thyroiditis, but other painless thyroiditis may have these antibodies. And they can also be seen in Graves' disease as well. So which means it's not specific for any particular disease. But remember, in Hashimoto's, the titers are going to be extremely high. Whereas in other painless thyroiditis and Graves' disease, the titers will be low, but still can be positive. Clear? That's why these are not considered to be very specific for Hashimoto's in the first place. So TSH receptor antibodies, again you have two different types of TSH receptor antibodies. One is called the thyroid stimulating immunoglobulin that stimulates the TSH receptor, and second one is the thyroid binding inhibitory immunoglobulin, that's called TBII. Remember the fact that TSI is going to be relatively more specific for Graves' disease. And in fact, whenever this antibody is found, I'm going to take it for granted that this is a Graves' disease only. And thyroid binding immunoglobulin, inhibitory immunoglobulin, TBII, is relatively less specific because it can be seen in patients with Graves' disease, or very rarely it can be seen in patients with conditions like hashitoxicosis, which I'll be discussing in some time, but rare. Hashitoxicosis. Clear? But this thyroid stimulating immunoglobulin is absolutely specific for Graves' disease, relatively more and more specific. And one more interesting fact is the one to know that this anti-TPO antibodies are associated with stillbirths and is associated with infertility in younger population. So very, very important point. That's why this anti-TPO is one of the commonly performed antibodies in infertility clinics also. So they are associated with stillbirths and infertility. Clear? These are some of the important antibodies that you perform. So remember, the TS receptor antibody is typically performed in a patient with suspected Graves. Anti-TPO in exam means is typically performed in a patient with suspected Hashimoto. But please do understand, anti-TPO is not specific for Hashimoto's disease or any other thyroid disease as such. And third investigation that you're going to perform is the ultrasound. Ultrasound. Clear? Ultrasound is generally performed to assess 2 to 3 functions of the gland. One is the vascularity of the gland. Clear? Using Doppler, you can find out the vascularity. But again, assessing the vascularity is important for assessing Graves' disease patients, because Graves' disease patient, you are going to have a very increased vascularity. At the same time, if you have a thyroid nodule and you have a central blood flow, that is actually more in favor of a malignancy, whereas if you have a peripheral blood flow, that is in favor of a benign lesion. So again, ultrasound vascularity assessment can be used in many different conditions. Diffuse increase in vascularity throughout the gland is more in favor of a Graves' disease. So second, you are going to assess the nodularity. Based on the nodularity, you can tell there is no nodule or just a diffuse goiter is there in the patient, or a normal gland, diffuse goiter versus normal looking gland. So if it's a solitary nodule or a single nodule, or if you have a multiple nodules, which means you are encountering a multinodular goiter. Remember, this solitary nodule only is going to increase the risk of malignancy, chance of malignancy. I'm not telling always malignant. They increase their, they are having high risk of malignancy. But this multiple nodules and no nodules usually have reduced chance of malignancy. They have reduced the chances of being malignant. Even multiple nodules will have reduced chance of being malignant. But solitary nodule, yes, I'm telling they can be or they cannot be. For example, 95% of the solitary nodules still tend to be benign only. Only 5% of the solitary nodules tend to be malignant. The most common benign solitary nodule will be a follicular adenoma, and the most common malignant solitary nodule will be a papillary thyroid carcinoma. You know that. PTC is the most common cancer in the thyroid. And the third thing that you can assess is the presence of significant enlarged cervical nodes. Remember, in the presence of a solitary thyroid nodule, when you have a enlarged cervical nodes, it's most of the times it will be malignant only, because it means it's a nodal spread. Usually PTC is the one that's going to have a nodal spread, and you can suspect a PTC in those conditions also. Clear? So, but based on ultrasound, how can you characterize a solitary thyroid nodule? You can put them under high risk lesions that are likely to be malignant, and you can put them under low risk lesions that are likely to be benign. What are the high risk features? The most important and the topmost feature I will tell you is the lesion that is taller than wider. That is going to be highly malignant most of the time. Or if the patient is having micro calcifications in the lesion. And sometimes these micro calcifications in B mode ultrasound can produce this twinkling appearance. Twinkling means appearance and disappearance, sudden appearance and disappearance. Because of the micro calcifications, they might produce that twinkling appearance in the lesion. So this is again a very, very important sign of a PTC, papillary thyroid cancer. It's been considered as one of the highly specific signs for PTC. And if they have rim calcifications, or if they tell you calcification that is present on the corner, on the side, or extrusion through calcification. So all these words are very important. Again, it's going to tell you it's a malignancy. Then if the patient's having a lesion that is more than or equal to 2 centimeter, large lesions, again high risk of malignancy. Or the patient is having hypoechoic lesions, high risk of malignancy again. Or if the lesions are having central blood flow rather than a peripheral blood flow in ultrasound, again high risk of malignancy. Then if the patient is having irregular borders in the lesion is showing irregular borders, or if they are having irregular halos around the lesion, again, it's a high risk of malignancy. Or if the patient is having associated cervical nodes, I told you already, and again, this is a high risk feature. So these are the things that you have to know that will tell you that the patient is having increased risk of malignancy. Remember, in this, the most important will be these four, that taller than wider, then microcalcifications, rim calcification, irregular borders, and probably this twinkling appearance due to microcalcifications. All these things, definitely they tell you there is high risk of malignancy in this patient. So what are the features that will tell you the patient is having a low risk of malignancy? One is cystic appearance or spongiform appearance. Spongiform appearance, or if the patient is having large calcification, large or coarse calcification rather than a microcalcification. Or if the patient is having comet-tail artifacts, and again presence of this comet-tail artifacts will tell you it's likely to be a benign lesion. Clear? So peripheral vascularity or peripheral blood flow. I told you there is central blood flow, here peripheral blood flow or peripheral vascularity. So all these things will tell you that the patient is likely having a benign nodule or a benign condition. So these are the ultrasound risk factors. And remember, ultrasound based interpretation is also now gone to a new different step by asking something called Thyroid system. Clear? So TIRADS is similar to that of BIRADS. It's called as Thyroid Imaging Reporting and Data System. So this is what we refer to as TIRADS. And TIRADS includes a lot of things under this, lot of features in ultrasound that will be put under different scoring systems, and they're going to calculate the total score, and they're going to tell whether you want to biopsy or not. So that's what we call TIRADS. So based on TIRADS, we are going to find out the echogenicity of the gland. So there are a lot of features. I'm only going to tell the features, not the exact things. So echogenicity of the lesion we are going to see first. Then we'll be seeing the echogenic material or presence of echogenic foci in the lesion. Then what will be the composition of the lesion? Then what is the shape of the lesion, whether it's regular or irregular or taller than wider, what is the shape of the lesion, and what will be the margins of the lesion, again whether it's regular or irregular. Shape means taller than wider or wider than taller. So that's what we're going to consider in the shape. So echogenicity as a point of 0 to 3 and echogenic foci as again a point of 0 to 3. So yeah, this bunch of distribution of points are there. According to the composition, it is divided into 0 to 2, whether it's cystic or solid. And I didn't tell you this, solid lesions have more risk compared to cystic lesions. Or even cystic lesions with mural solid echogenicity, again they are having high risk of malignancy. Clear? So solid components means high risk of malignancy. Shape, again you are going to get only two things, that is 0 and 3. Suppose if it's wider than taller, I'll make it 0. If it's taller than wider, that itself gives you 3 points. That's why that's on the topmost chart. And about the margins, you're going to have 0, 2 and 3. You're not going to have 1 here. So here there is no 1 and 2. Here there is no 1 at all. Here it's only 0, 2 and 3. Suppose if you calculate the total score, the score will range from 0 to 14. This will be the score range. In this, based on different types of scores, you can tell whether the patient needs a biopsy or not. Suppose if it's a TIRADS 1, the score must be 0. 0 or 1. Score of 2 will come under TIRADS 2. Score of 3 will come under TIRADS 4. And score of 4 to 6 will come under TIRADS 4. And score of more than or equal to 7 will come under TIRADS 5. So this TIRADS 1 and 2 usually need not be biopsied according to the guidelines. And this TIRADS 3, 4 and 5 has to be biopsied for sure. So what will be the threshold for biopsy? Which means what should be the size of the lesion so that you can biopsy. The threshold for biopsy in TIRADS 3 is 2.5 centimeter. The threshold for biopsy in TIRADS 4 is 1.5 centimeter. The threshold for biopsy in TIRADS 5 is just 1 centimeter. So this is the TIRADS system. It's a new system, so which means it could be a probable question in your institute exam, so you better know this. So this is what we refer to as a TIRADS system, Thyroid Imaging Reporting and Data System. Fine. So after knowing this many details on ultrasound, we are moving on to the next investigation, that is FNA, that is fine needle aspiration, which can be done along with cytology, or you can go for a fine needle aspiration biopsy. So ideally we prefer a cytology. Clear? FNAC is the common term that we prefer, fine needle aspiration cytology. So remember, there are some indications for FNA. FNA is considered as the investigation of choice for assessing any thyroid nodule. To assess a thyroid nodule, FNA is often considered as the investigation of choice. Very important point. But the first investigation to assess thyroid nodule will be always thyroid function test, TSH. But the best investigation to assess the thyroid nodule is FNA. So when can you FNA, or when can you biopsy, or when can you do an aspiration of a thyroid nodule? Especially if it's solitary, there are 3 indications are there. First indication, any nodule more than or equal to 2 centimeter definitely has to be biopsy. Second, nodules that are 1 to 2 centimeter in size, plus if you have high risk ultrasound features. We have just now discussed on the high risk ultrasound features. So if there are any of the high risk ultrasound features, you can biopsy them. If the nodules are less than 1 centimeter, then also you can biopsy. But if the patient is having high risk clinical features, so if the patient is having high risk clinical features, then even if it's less than 1 centimeter, you can do the biopsy. So what are the things that will tell you that the patient is having high risk of malignancy in a clinical feature side? So clinical features that are suggesting that the patient is having high risk of malignancy. Point number 1 is male sex itself. Point number 2, extremes of age. Suppose the patient is having age less than 20 or age more than 65. Or if the patient is having history of irradiation to the neck. Irradiation to the neck and the related area. For example, because of the Hodgkin lymphoma, they would have gone for some irradiation to the neck. Fourth, if the patient is having family history of thyroid cancer, or even a polyposis of the colon, which is associated with high risk of thyroid cancers as well. So family history of thyroid cancer especially. Number 5, if the patient is having solid, immobile and fixed nodes, solid, immobile, hard or fixed nodes, fixed mass, fixed nodule. So that will tell you that's likely to be a malignancy, high risk clinical feature. Next, palpable cervical nodes. The patient is having palpable cervical nodes. All these things will tell you that the patient is having high risk for malignancy. So even if it is less than 1 centimeter, if you have any of these high risk clinical features, you can take the patient for FNAC. So these are the indications for FNAC. Very simple, any nodule that is more than 2 centimeter or 1 to 2 centimeter plus high risk ultrasound features, or less than 1 centimeter with high risk clinical features. So all these things are indications for doing a FNAC. Remember, it is the investigation of choice for assessing a thyroid nodule. One pitfall about this FNA, which is very, very commonly asked in exam, is the fact that it cannot differentiate a follicular adenoma versus a follicular carcinoma. Follicular carcinoma. Very, very important point. It cannot differentiate a follicular adenoma versus a follicular carcinoma because the differentiation is based on the capsular and vascular invasion. So this capsular and vascular invasion can be identified only by a biopsy, by excision biopsy usually. So with that only you can identify. Otherwise you cannot identify this capsular and vascular invasion. That is the reason why FNAC is inadequate in differentiating a follicular adenoma versus a follicular carcinoma. That's why whenever the pathologist suspects a follicular neoplasm, follicular carcinoma or adenoma, he won't give it as a follicular adenoma or a carcinoma. He will be just giving it's a follicular neoplasm and he will not give a adenoma as a carcinoma because you need a biopsy to tell whether it's an adenoma or a carcinoma. Now let us see how the FNA will be reported. The results in FNA will be reported. Results in FNA will be reported in the form of 5 nomenclatures, that is Thy1, Thy2, Thy3, Thy4 and Thy5. This system of reporting is what we refer to as a Bethesda system or Bethesda classification. Thy1 means it's typically non-diagnostic, and Thy2 means we can call them as non-neoplastic or a benign lesion. This Thy3 means this is nothing but atypia of undetermined significance or a follicular lesion of undetermined significance, FLUS. So this is how they're going to report. Thy4 means it's likely a follicular neoplasm, and Thy5 means is a suspected malignancy or there is a high degree of suspicion for malignancy. And if it's Thy6, you have sure shot malignant lesion. It's a malignant lesion. Clear? So this is how they're going to report. This is what they're going to report according to the Bethesda system. In this, if you name it as Thy1, in this you have to repeat the FNAC. There is no other option because it is coming as non-diagnostic. In Thy2, you know it's surely a non-neoplastic and a benign lesion. So in this condition, just an observation is enough. Whereas this Thy5 and Thy6, it's a suspected malignancy or it's a surely malignant lesion. In this condition, it is better to do a total thyroidectomy. In patients who are having this Thy3 and Thy4, it is something difficult to interpret what you have to do, but still you can consider doing a repeat biopsy, or you can do some molecular testing in the same sample and the same specimen, or you can easily go for a hemithyroidectomy and send the sample for excision biopsy, which is more easier. So these are the things that you can do for Thy3 and Thy4. Remember, this Thy3, 4 and 5 are difficult to interpret through FNAC, which means they are difficult to interpret lesions. They are not easy to interpret, they are very difficult to interpret by FNA. So that's why you are doing some different efforts for Thy3, 4 and 5 lesions. But remember, this is how Thy1 means repeat FNA, Thy2 means just observe, Thy3 and 4 means either you can repeat biopsy or you can go for a hemithyroidectomy or you can do other molecular testing methods. And Thy5 and 6 generally we go for total thyroidectomy. That's what we're going to do. So these are the different steps you are going to do based on the FNA reports. So FNA has a lot of importance. So this much if you know, that is more than enough. So what are the indicators for FNA? That's the most important question in the exam. And second thing, what is the Bethesda classification system and what is the interpretation and how you are going to approach this Bethesda reporting system from FNA. Then at the same time, how you are going to understand the pitfall of an FNA, that is, it cannot differentiate between a follicular adenoma versus a follicular carcinoma. So these are three standard things that will be asked in your exams. So we don't have a space, but the next important investigation is the uptake scans and scintigraphy. This is a huge topic, uptake and scintigraphy. There are lots and lots of indications for this uptake and scintigraphy. Basically, there are two different things. Uptake is not the same as that of scintigraphy. Let me tell you how. So the uptake scans means you are going to use the amount of radiotracer uptake. So you're going to see how much of the radiotracer uptake is seen in the thyroid gland. So that's what you're going to see by the uptake scans. In the scintigraphy, you're going to image the gland. So which means you're going to take a snapshot of the gland and see what is happening along with the radiotracer. So these are nuclear scans. And for this purpose, we are going to use two different radiotracer molecules. One is the standard I-123, clear? So this is the standard. And second one is the technetium 99M pertechnetate scans. Remember, for all practical purposes, it's always better to use a I-123, and this type of I-123 mediated testing of uptake scans is what we call as radioactive iodine uptake, RAIU. Remember, it is different from RAIA, that is ablation, that is different. We're talking about radioactive iodine uptake where we prefer the radiotracer called I-123, not 131. 131 can be actually used, but since they deliver more of particle emission. So because they do that beta particle emission, so that is actually can be captured by thyroid and more damaging. For a diagnostic reason, you need not give that much high radiation dose to the patient. So that's why you use I-123, which is not going to emit beta particles at all. It's going to emit only gamma. Technetium 99M is also going to emit only gamma. Remember, the half-life of I-123 is approximately 13 hours, whereas the half-life of technetium scans, any technetium tracer half-life will be 6 hours only. Remember, technetium scans will test only the uptake, only the uptake. It will not test the organification step. So, radioactive iodine has a unique advantage. It can check both uptake as well as the organification process. You know what is organification? See the physiology video if you have not watched it. So organification is nothing but binding of the iodine with the thyroglobulin. Technetium 9NM, even though it can enter the thyroid cell, it cannot bind to the thyroglobulin like iodine. But iodine 130, 123 or 131 can do that as well. So that's the reason. So uptake and organification both can be tested. So that is why RAU scans are a little bit slow. It might take some time. Usually we do the first scan at 4 hours after giving the tracer, and the next scan will be done at 24 hours after giving the tracer, because the first is to check for the uptake and the second one is to check for the organification. Clear? But these scans can be just taken within 20 to 30 minutes. That's the biggest advantage of technetium related scans, because they are very, very rapid and fast. You can finish the scan within 20 to 30 minutes. That's why many of the physicians right now prefer the technetium scans for scintigraphy as of now. Even though it's not totally accurate and totally specific, but still it is preferred because of the fastness and the rapidity of these scans. At the same time, what is the dose that is delivered in the radioactive iodine uptake? It's a little bit higher dose, that is 100 to 400 microcurie. This is the dose that is delivered. The dose that is delivered through the technetium tracers is just 3 to 5 microcurie. Very, very less radiation. And that's also one reason that world might be trying to move towards this technetium scans. Along with the rapidity, this is another unique advantage. Similarly, this technetium scans can be used in this breastfeeding mothers. A lot of studies do tell that they are safe in breastfeeding mothers, especially if they are not going to give breast milk at least for the next 6 to 12 hours. It's enough. You can use this technetium scans. But radioactive iodine needs a larger time period before you can start the breastfeeding again. So which means I cannot use this in breastfeeding mothers, because please do understand that iodine is going to concentrate in the breast milk. I told this point many times. So even if you give this I-123, they are going to concentrate in the breast milk, and the child unnecessarily is going to get exposed to this I-123 and related radiation. Clear? So you're not going to do that. Absolutely, both this testing are contraindicated in pregnancy. There is no doubt about that. They are absolutely contraindicated in pregnancy, without a doubt. Without a doubt, they are absolutely contraindicated in pregnancy. You cannot use any of this testing in pregnancy. Clear? So these are the different uptake and scintigraphy that you're going to use. I told you the difference between uptake and scintigraphy. So in that matters, you have to know what is the normal uptake. Uptake and scintigraphy both are generally generated through using some gamma cameras. So we are going to use two instruments here. One is a gamma camera, and second one we use a collimator. Collimator is the thing that images the thyroid. So collimator. So collimator currently we prefer is a pinhole collimator than a parallel collimator. I mean, previously we have been using a parallel collimators. Now we use a pinhole collimator for a better magnification of the thyroid. Okay, so gamma camera with the collimator. This is what I'm going to use. Uptake wise, we are giving a dose of this technetium 9 and some amount of radiation dose you are giving. We know that. We are quantifying that before giving. So how much is coming from the thyroid after giving this dose of traces? So that's what we're going to test by the uptake, which can be simply taken by the gamma camera or measured by the gamma camera itself. So the normal uptake in the radioactive iodine is approximately less than 15 to 25%. So this 15 to 25% of tracer uptake is considered to be normal. If it is more than 50 to 80%, we call it as increased uptake. If it's less than 5 to 10%, we call it as reduced uptake. Remaining are gray areas. 15-25 is the usual normal uptake of a I-123 radioactive iodine uptake, whereas more than 50 to 80% we call it as increased uptake, and less than this 5 to 10% we call it as a reduced uptake. Similarly, the normal uptake based on the technetium-based tracer is 1 to 4%. If it is more than this, we call it as a increased uptake. If it is less than that, 1%, we call it as a reduced uptake. So this is the normal uptakes that you have to know at least. So which can be simply measured by the gamma camera itself, because they are going to emit gamma radiation. That's it. But scintigraphy needs this collimator also. So scintigraphy means you are going to image the thyroid gland. You are going to actually see the thyroid gland and the amount of radiation coming from the thyroid gland in different places, and you are going to map it with the help of a computer. So based on thyroid scintigraphy, what are the things that you can find out in your patient with the suspected thyroid disorder? So indications of uptake scans in scintigraphy, the number one indication is always primary hyperthyroidism. Remember, uptake scans are not usually useful in hypothyroidism except for few cases of congenital hypothyroidism. But these are most important and most valuable in patients with the primary hyperthyroidism. Very important. I'll tell you in some time. Second, when the patient is having a suspected congenital hypothyroidism. So I'll tell you why. In suspected congenital hypothyroidism, there can be thyroid hypoplasia, or that is called athyrosis, or the patient might be having an ectopic thyroid which may not be functioning properly at all, like a lingual thyroid or a mediastinal thyroid. So we don't know. So to do that, identify the ectopic thyroid or whether the thyroid is present itself in the first place or not, we can use this uptake and scintigraphy. Number 3, for evaluating functional evaluation of a solitary thyroid nodule. Functional evaluation of a solitary thyroid nodule. Very important again. Number 4, you're going to use in patients who are having thyroid malignancy. How you're going to use in thyroid malignancy? Not pre-op. Pre-op, there is no role. I mean, usually. In post-op, it's very important. When you know it's a thyroid malignancy, means in post-op it's going to have a high value. Especially, you can do something called pre-treatment scanning. So this terminologies right now may be confusing, but once you understand the remaining topics also, it will be easy. So what do you mean by pre-treatment scanning? After this thyroid malignancy, post-op means you do a total thyroidectomy. Any thyroid malignancy, the best treatment is total thyroidectomy. You did a total thyroidectomy, and after doing a total thyroidectomy, you are going to use another adjuvant therapy called as radioactive iodine ablation. So again, there are some indications for this radioactive iodine ablation, which I'll be telling in some time in the thyroid malignancy section. But right now, understand there is an adjuvant therapy called radioactive iodine ablation therapy after the thyroid surgery, after this total thyroidectomy. But after this total thyroidectomy and before doing this radioactive iodine ablation, you can do something called a pre-treatment scanning, which means to identify where are the metastatic deposits are there, and also to identify is there any residual disease that is present in the gland itself. So to do that, you do something called a pre-treatment scanning. So for that also you can use this uptake scans and scintigraphy. Especially in those conditions, we prefer a scintigraphy. Uptake is not that important there. Scintigraphy is the most important because you are going to identify by imaging where are the other areas of metastatic deposits, or is there any loco-regional disease that is left in the gland. So these are the 4 indications why you're going to do a uptake scan. In this, the most important is going to be the primary hyperthyroidism evaluation. Clear? So whenever you are having a primary hyperthyroidism, which means patient is having a low TSH with a high T4, how you can evaluate using uptake scan. Uptake scans are the ones that are going to be the standard clues for the further diagnosis. So now check for the radioactive iodine uptake or technetium 19 per technetium based uptake. So in this, you can differentiate into primary hyperthyroidism cases with increased uptake or primary hyperthyroidism cases with reduced uptake. Clear? So when you have a primary hyperthyroidism with increased uptake, you have to see what is the type of uptake in scintigraphy. So next is to see the scintigraphy and see what is happening. Where is the how is the distribution of this uptake? So you can categorize into a diffuse increased uptake, or you can categorize into multifocal increased uptake, or I can call a patchy multifocal increased uptake. Or third one, you can see in a patient who's having a focal increased uptake. Focally increased uptake. So diffuse increased uptake usually is unequivocally means the patient is having some stimulating antibodies or stimulating TSH receptor antibodies or stimulating antibodies of the TSH receptor. You know very well why this is happening. So when you have a Graves' disease or any other condition that produces, obviously one of the most important and the most common and the specific condition that produces this stimulating antibodies for the TSH receptor is the Graves' disease. So what's going to happen is you have a lot of TSH receptors, and remember this antibodies are going to bind with this TSH receptors and they're going to stimulate the TSH receptor. I told you once you stimulate this TSH receptor stimulation by TSH is one of the powerful stimulators for uptake of iodine, radioactive iodine. Clear? So that is the reason that they are going to have increased uptake. But because they are going to stimulate the TSH receptor, this gland is going to produce excessive hormones, and this by feedback should definitely suppress the pituitary and the hypothalamus, and they'll produce low TSH only. Which means this patient is having low TSH with high T4 means it's a primary hyperthyroidism only. But remember, even though the TSH is low, because some students do ask, you told the TSH is the most important stimulator of the gland to take up the iodine and produce thyroid hormone. But how here, despite having low TSH, why the patient is having increased uptake? That is because these antibodies are simulating the TSH. These are TSH receptor antibodies which are like TSH and they are acting on the TSH receptor and they are stimulating like TSH. That is why you are having this high uptake. So whenever you have a diffuse increase in uptake, it's always specific for presence of TSH receptor antibodies that are stimulating type. And the most important condition that you have to know is Graves' disease. In fact, this is the only condition that you have to diagnose in practical scenarios. But very, very, very rarely, there is an entity called hashitoxicosis that can also present like this picture, but very, very rarely. Do not answer this in exam. Clear? It's always the Graves' disease. Diffuse increased uptake means it's Graves. That's it. If it's multifocal patchy increased uptake, always goes towards a toxic multinodular goiter, otherwise referred to as a Plummer's disease. Is also referred to as Plummer's disease. If it's a focal single increased uptake, it indicates a solitary toxic adenoma. Solitary toxic adenoma. Clear? Now, suppose if you are having reduced uptake, remember whenever you have a hyperthyroidism with reduced uptake, it almost always gives you one diagnosis, like in your exam, that is destructive thyroiditis. Any destructive thyroiditis can have a reduced uptake. The reason is very simple. Remember, in a destructive thyroiditis, the problem is the gland is destroyed, and because of the destruction of the gland, they are releasing a lot of thyroid hormones, stored thyroid hormones. That's why your T4 levels are high, and that is the reason for thyrotoxic features in the patient. And this definitely is going to give a feedback to the pituitary, and this pituitary is going to produce low TSH and they're going to suppress the TSH. Remember, this low TSH is going to definitely make the gland cold only, and they will not take up any iodine at all because you are having low TSH in this condition. But remember, in Graves' disease, something else has happened. That the patient is actually getting stimulated, the thyroid is getting stimulated by antibodies, not the TSH there. Here the TSH is low, that's why the gland will be cold in any destructive thyroiditis. For example, it could be painless or it could be painful destructive thyroiditis, doesn't matter. Painful destructive thyroiditis means it's a decurrence thyroiditis, which we'll be discussing, and we are having a separate section on thyroiditis. So it's again low uptake condition only. This is what your exams will ask. Definitely low uptake, always in exams you think about a thyroiditis. Clear? Then you have other conditions. Suppose if you have a ectopic thyroxine excess, it is not coming from the thyroid gland. You are having some other source of this ectopic thyroxine. Again, you can result in a reduced uptake. Let us see how. In this condition, the gland is normal, not destroyed, But remember, this T4 is coming from a different source. It's not coming from the thyroid. And this T4 that is coming from a different source is in excess here, and it's producing thyrotoxic state and hyperthyroidism. And now this excessive T4, definitely, they are going to suppress the pituitary and they are going to produce low TSH only. This low TSH, obviously the gland is now responding normally and they will make the gland cold only and they will not take up any tracer at all. So here also you have high T4 with a low TSH and the gland that is appropriately responding to this low TSH producing, cold areas. Clear? They're not going to take up the tracer at all. So in this condition also you will be having low radioactive iodine uptake only, but there are two reasons why you have this ectopic thyroxine excess. This ectopic thyroxine can be coming from two areas. One, it could be an endogenous source or it could be an exogenous source. Endogenous source of ectopic excess thyroxine means it's coming from a tumor like struma ovary. It's coming from a tumor like a struma ovary. Exogenous ectopic excess thyroxine means the patient is actually knowingly or unknowingly taking a lot of excess thyroxine tablets from outside. So which means this disease is what we refer to as thyrotoxicosis factitia, where the patient knowingly or unknowingly might be taking excess thyroxine from a different source through mouth. So very commonly this thyroxine is actually mixed in the weight loss supplements because thyroxine produces a good amount of weight loss. So they can be mixed in the weight loss supplements that is consumed by women. They might come with severe menstrual irregularities and weight loss. They might be taking some weight loss supplements. Ask that history particularly. Or even I have seen a case where an elderly couple is living. The man is having some vision problem and his wife is actually taking thyroxine tablets, and this man unknowingly, instead of taking the vitamin tablets, is taking his wife's thyroxine tablet for a long time without his knowledge, thinking it's a vitamin tablet, and this man is growing thinner and thinner and is getting thyrotoxic features including anxiety, insomnia, hypertension and all these things. And we finally found out that this is the cause. And because we started evaluating for all these disorders and the patient started showing the labs as primary hyperthyroidism, then we did an uptake scan. There was nothing, no uptake in the uptake scans at all. In the thyroid looks completely silent. Then we started thinking about thyroiditis, but this patient had no features of thyroiditis absolutely and didn't resolve at all. So when we started going back to the history and we asked a thorough history, and this is what the case, and we found out, and this is a very funny case, and we encounter these kind of cases, and this is what we refer to as something called a thyrotoxicosis factitia. And if they ask you how will you differentiate between a thyrotoxicosis factitia and struma ovary, the thyroglobulin levels will be elevated if it's endogenous release of thyroxine. For example, even in a thyroid that is causing hyperthyroidism, the thyroglobulin levels will be elevated. Whereas exogenous consumption of thyroxine tablets, see, you're taking only levothyroxine. You're not taking along with thyroglobulin also. So you will have low thyroglobulin levels only. So this is the most important point that will go towards a thyrotoxicosis factitia. Very important point again. Clear? Low thyroglobulin levels. But if it's endogenous release anywhere from the body, either struma ovary or from the gland itself, it will be definitely showing excessive thyroglobulin levels only. So this is again a very important point. So now you can see very clearly how the uptake scans are beautifully defining your hyperthyroidism diagnosis. Clear? And in toxic MNG, what you will see? In both these conditions, whether you have a toxic MNG or you have a toxic adenoma, the gland is actually having autonomic hyperfunctioning nodule. That is a problem here. In both these conditions, the patient is actually having a autonomic hyperfunctioning nodule in the thyroid. Remember, if the patient is having a single nodule that is hyperfunctioning, which means it's autonomic in the sense, this is not going to care about the TSH at all. They are going to produce excessive T4 no matter what about the levels of TSH. They are autonomic and hyperfunctioning, which means they are going to produce excessive T4, and obviously that will suppress the TSH. And since the TSH is suppressed and the rest of the gland apart from this nodule is normal, they will be having low uptake only. And only this autonomic area, that is not responding to this TSH and continuously producing high T4 will take up more iodine and they will look bright in the imaging. So if you have a single nodule like this, autonomic hyperfunctioning nodule, that goes towards a solitary toxic adenoma. If you have a multiple autonomic hyperfunctioning nodules like this, then it goes towards a toxic MNG. That's all. That's Plummer's disease. So in toxic MNG and solitary toxic adenoma, the rest of the gland will be normal only. I mean, in fact, they won't take up iodine properly and they will look cold only. The areas that are hyperfunctioning are the ones which are going to look very hot and they are going to take up the tracer and they're going to concentrate tracer intensely. So now you can understand how this radioactive iodine uptake and the scintigraphy scans are extremely helpful in understanding the causes of primary hyperthyroidism. That's why I told you it's one of the quintessential techniques to evaluate a case of a primary hyperthyroidism. Remember, secondary hyperthyroidism, you don't need this uptake scans in the first place because high TSH and high T4 or a high T4 with a normal TSH will surely tell you it's a central hyperthyroidism and you're going to directly do a pituitary imaging to look for the mass. And again, remember, that's a very, very rare cause because central hyperthyroidism, you have only two causes, isn't it? One, it could be a thyrotroph adenoma, which is extremely rare. Go back to the pituitary adenoma section and see, I would have told the thyrotroph adenomas are the rarest form of pituitary adenomas, less than 1% incidence. At the same time, this other cause of central hyperthyroidism are again very, very rare, like thyroid hormone resistance, like TR beta mutations. I told you they're very, very, very rare. The TR beta mutations are otherwise referred to as pituitary thyroid hormone resistance as well. I've told you all this in the previous video. Go back and watch. Okay, so the first indication is over. Now we are going to the second indication to diagnose a congenital hypothyroidism. Remember, congenital hypothyroidism can be due to thyroid hypoplasia. That is called athyrosis or thyroid hypoplasia. Or it can be due to ectopic thyroid tissue that is non-functional. Ectopic thyroid gland that is non-functional. Again, this uptake scans and scintigraphy is very useful here because if you see ectopic thyroid near the tongue, that's a lingual thyroid, or it could be in the mediastinal thyroid, but that is non-functional, definitely you will have tracer accumulation, but that is not releasing sufficient thyroid hormone. So that's why the reason is, but if you don't see any ectopic tissue and you don't see any tracer accumulation in the thyroid area also, definitely it is going towards a thyroid hypoplasia. So very easy to find out. So that's why it's a very important investigation. I'll show you the images in some time. So functional evaluation of a solitary thyroid nodule. Again, very important. How? Let us see. So whenever you have a solitary thyroid nodule, you know, the first investigation you're going to do is TSH or the TFT. I told you many times this point. When you do a TSH levels can be either suppressed or TSH levels can be normal or decreased. When the TSH levels are decreased means you are probably dealing with a case of a primary hyperthyroidism. That's why TSH is low. In this condition, you do a radioactive iodine uptake. Obviously, I told you the best area where you can do radioactive iodine uptake is primary hyperthyroidism. That is why in the presence of a low TSH, you're preferring a radioactive iodine uptake or probably a technetium 9nm scan. So radioactive iodine uptake is showing excessive uptake, which means a hot nodule. Hot nodule means that takes up excessive iodine compared to the surroundings. You call them as hot nodules. So usually this lesion is likely to be benign. I'll tell you what are the incidences of malignancy in these lesions. Likely to be benign. Suppose if the patient is having a normal or a reduced TSH, what are you going to do? In this condition, you have to see whether is there any criteria for FNAC is there or not. Criteria for FNAC. I told you the criteria for FNAC, any lesion more than 2 cm or 1 to 2 cm lesion with high risk ultrasound features or less than 1 cm with high risk clinical features, which we had discussed already. So if no, you can just observe this patient with serial ultrasound scanning probably. If yes means you can actually take this patient for FNA. Similarly, if the patient is having a warm or a cold nodule, and again you have to see the criteria for FNA and based on that you can take for FNA. I mean if the criteria fits in or not. So very, very simple. This is how you approach a solitary thyroid nodule. So here you can see in uptake scans, warm and cold means actually you are checking for the criteria for FNA, which means what I am trying to tell is, in a radioactive iodine uptake, if you encounter a cold nodule, which means cold nodule means the nodules which are going to take up less iodine compared to the surrounding. It look cold, or that area will look washed out. So if that is the case, the risk of malignancy is approximately 10 to 20%. If you encounter a cold nodule, the risk of malignancy is 10 to 20%, very high. If you encounter a warm nodule, what do you mean by a warm nodule? The uptake in the nodule is almost same as that of the surrounding area, which means you cannot differentiate in radioactive iodine uptake, but still you see a nodule. So in this condition, the risk of malignancy is approximately 5 to 10%. If you encounter a hot nodule, which means the uptake in the nodule is more than that of the surrounding area, here the risk of malignancy is less than 1%. That's why I told you whenever you encounter hot nodule, it's likely to be benign. So that's the reason I told you for functional evaluation of a solitary thyroid nodule, you can do this FNA scans, radioactive iodine uptake scans or technetium based uptake scans also. Remember, for functional evaluation of this solitary thyroid nodule, no uptake scan can concretely tell it is a cancer. Remember, I am just telling it's likely benign, or I am just seeing the criteria for FNA. I am not telling that it is malignant by uptake scans. Please understand that point. You cannot have a good specificity with uptake scans or scintigraphy to diagnose a cancer. So diagnose a cancer, you need an FNA or a biopsy, that is for sure. With uptake scans, you can only suspect it's a probable cancer, especially if it's a warm or a cold nodule. But you cannot rule out a cancer completely, or you cannot even confirm a cancer, which is even more important. You can never confirm a cancer. Clear? With radioactive iodine uptake or any other scintigraphy scans. That is the reason why they have proposed a newer scan system called as technetium 99M SESTA-MIBI, or you can simply call it as technetium 99M MIBI. And again, the importance or the specificity of this scan to diagnose a tracer, diagnose a malignancy, is completely unknown. But it has been proposed that this technetium 99M MIBI or SESTA-MIBI scans can be useful for identifying a differentiated cancer. Differentiated cancer, which means I'm not talking about anaplastic. Differentiated means it should be a PTC, FTC, or a MTC. Not an anaplastic cancer. For differentiated cancers, the tracer accumulation of MIBI in those cancers might be useful. Suppose where it will be useful, especially when you have a cold nodule. Let us say you have a cold nodule in routine uptake scans and you are doing a MIBI scan. In the MIBI, you are seeing increased uptake. So this is said to be relatively specific for cancers like papillary thyroid cancer, which means you are actually encountering a cold nodule in other uptake scans and scintigraphy like radioactive iodine uptake. You are doing RAU and you are seeing a lower uptake or a cold nodule. And after that, you are doing a MIBI scan. And in the MIBI scan, if you see excessive uptake, that is actually more going in favor of a malignancy. Clear? So this has been proposed, but again, we don't know the validity. So what is the validity of this data? We don't know. And again, you need a lot of trials to check the validity of this data, but still this is still on. Clear? So anyway, so finally, this is going to be important flowchart for your exams, how you are going to approach a solitary thyroid nodule. At the same time, I also told you it's important for thyroid, once you diagnose a thyroid malignancy, because if you have diagnosed a thyroid malignancy means you have already in this step, you have did an FNA and you have diagnosed a thyroid malignancy. So after diagnosing thyroid malignancy, before the operation, there is no role for any uptake scans. I mean, when is the role? I told you already, for pre-treatment scanning. So before doing a radioactive iodine ablation, after a total thyroidectomy, these scans might have a role to determine the metastasis or probably a loco-regional bulky disease. All these things can be identified by this scan. So probable importance is there here. So for this, the tracer that we use is I-131. For this post-op pre-treatment scanning, the tracer we prefer is I-131, not I-123. Again, I'll tell you, there is a lot of reasons behind that. Fine. So now we have discussed about the uptake scans as well. Clear? So next you have some miscellaneous investigations. Some other investigations or some miscellaneous investigations are there which are very rarely used. In that, the most important is the TBG, which is not at all used, thyroid binding globulin. You know what are the conditions that increase or decrease the TBG? We have discussed enough and in detail in the physiology section itself. So then you have the reverse T3. Again, reverse T3 is only importance is diagnosing a non-thyroid illness or a sick thyroid state where it will be increased and absolutely no value. You're not going to use clinically at all. And next is the thyroglobulin levels. Thyroglobulin levels, it's only used in places where the patient is having hyperthyroidism with reduced radioactive iodine uptake, where it can differentiate whether this thyroid hormone excess is coming from an endogenous source or it is coming from an exogenous source. If it's coming from exogenous, outside, the thyroglobulin levels will be low only. If it's endogenous, definitely thyroglobulin levels will be increased. For example, in a thyroiditis or in a struma ovari, the thyroglobulin levels will be high. Before going into the flow chart on how to evaluate a thyroid disorder, I'd like to tell these are the investigations that you have. You don't have any more investigations for thyroid gland disorders, and I have discussed everything in detail in the section which I have shown here. Clear? So now we'll see some of the images, then we'll move on to the flow chart. The first group of images I'm going to look out is the radioactive iodine uptake scans, or probably a technetium 9nm pertechnetate scans also. Both will look almost similar only. So let us see first the normal imaging. So how the normal scans will look like. You can see this as the normal thyroid, normal uptake, and this is the overall view of the gland. And you can ask me what are these? These are nothing but markers. So we have to have some markers as a comparison and standard. So these are the markers. Markers can be kept on different places. It can be kept on right side when the patient is getting imaged, or maybe placed on the suprasternal notch, or maybe placed on the chin also. This is called a chin marker. So anywhere you can keep the markers. That is actually like a standard for comparison. And this is an anterior view. This is a left anterior oblique view, which is good for seeing the left lobe, and this is a right anterior oblique view, good for seeing the right lobe. And then this is another normal imaging again in the RAO anterior and LAO views, where you can see one small tracer accumulation here. That's why I'm asking about. So there is a small tracer accumulation here. What is this? Sometimes you might get confused, but what is the tracer accumulation? It is nothing but the esophageal tracer, which means sometimes when these traces are actually drunk before starting the scan. So when you're drinking these traces, so that can get stuck in the esophagus somewhere, and that can show as a focal area of uptake. So to know whether it's an esophageal artifact or not, just ask the patient to drink water and then recheck the scan. Obviously that would have washed out and they have gone distally, at least because of esophageal peristalsis. So that's how you confirm it's an esophageal artifact. Then we are going to use this uptake scans for a patient who's having primary hyperthyroidism, which means this patient is having a excessive T4 and a low TSH. So the first possibility you can see, this is a intensely angry gland where it is having diffusely increased uptake. So if you see a gland like this in the presence of primary hyperthyroidism, it is for sure you are dealing with the patient with Graves' disease. Even though hashitoxicosis is one of the other relatively rarest differential diagnosis, but still you are going to diagnose practically only Graves' disease, because the treatment is again not going to change. This picture means the treatment will be the same like Graves' disease only. Clear? Which means this indicates the patient is having some TSH, stimulating TSH receptor antibodies. Then you can see this another patient with primary hyperthyroidism, where you cannot even see the gland. Where is the gland here? You can see the markers already, but there is no gland here, which means it is a diffuse, decreased uptake in the gland. So usually in exam, this always goes towards a thyroiditis. If you see this kind of picture, it always goes towards a thyroiditis only. Again, the differential diagnosis could be struma ovari or thyrotoxicosis factitia, which is again extremely rare. Then you can see multifocal increased uptake like this, where you're having other areas which are having normal or reduced uptake also. This is definitely a toxic multinodular goiter. In the presence of primary hyperthyroidism, I will be diagnosing this as a toxic MNG only, otherwise referred to as Plummer's disease. And this patient is having a primary hyperthyroidism with focal increased uptake in the gland. So this is suggestive of a solitary toxic adenoma in the presence of a primary hyperthyroidism. So that's why uptake scans are extremely useful in diagnosing case of primary hyperthyroidism also. And you can see this patient is having a solitary nodule. So which means you can use this uptake scans in evaluation of this solitary thyroid nodule also. And when you do uptake scan in this patient, you can see there is in the right lobe of the gland, there is a focal cold nodule. Remember, the cold nodule in a solitary thyroid nodule has a risk of 10 to 20% being malignant, the highest among other type of nodules. So this patient ideally has to be taken for FNA provided if there are some indications. Clear. So our uptake scan may also be used for diagnosing cause of congenital hypothyroidism. This patient is having a congenital hypothyroidism, proven case, but they are having a normal uptake. You can see the gland is having a normal uptake, which means here the problem is not ectopic thyroid gland or the problem is not thyroid agenesis, the problem is dyshormonogenesis, which means the hormone production and release or synthesis something is faulty, but the uptake is actually normal, which means the gland is located in the normal place and it's taking up the tracer normally, but something inside the gland is abnormal, so not producing enough hormones. And you can see this is a patient with an ectopic thyroid gland. In this case, it's the lingual thyroid here. You can see this uptake is near the tongue, but there is no tracer in the usual location, which means the thyroid gland is located near the tongue itself, which is not functional. And here you can see there is no ectopic gland. At the same time, there is no tracer uptake in the thyroid area also, which means this patient is having a thyroid hypoplasia or thyroid agenesis, otherwise referred to as athyresia. Clear? So that is the reason here. So that is how the uptake scans are useful in evaluating the cause of congenital hypothyroidism also. So this traces can be useful in patients who are having known thyroid malignancy. Known thyroid malignancy. We have discussed this already. Known thyroid malignancy also, this traces radioactive uptake scans are useful. So, but remember, in malignancy, the uptake scans will be useful only post-op, but before the treatment with radioactive iodine ablation. So that's why it's called a post-op pre-treatment scanning. For this purpose, I told you we'll be using I-131 only, because other case we are going to use I-123, not 131, but for this purpose we'll be using I-131. You can see when you zoom and see that this patient is having a local disease that is not cleared surgically, because probably that is a difficult mass to clear, which means it could have been encasing the major vessels or some removal may result in life-threatening complication like encasing the carotid. So sometimes difficult to remove. So that is a probable reason why the surgeon would have left in situ. So we are having evidence of local disease and active disease there. And you can see some nodal metastasis also. So that will come under the group called locoregional disease, and this patient will definitely be taken for radioactive iodine ablation. And you can see the same, but it's just zoomed, that's all. Similarly, this patient is having a local disease. At the same time, in multiple areas, there is tracer uptake, which means there are a lot of bone metastasis in this patient. Clear? So that's how your uptake scans are useful in post-op scenarios. So then I will show you some ultrasound images. So these are the classic twinkling sign. So twinkling means they come as blips. These hyperdensities come as blips and goes, and that are due to microcalcification that are floating. So this is what we call as a twinkling sign in B mode ultrasound. And this is a typical example of a thyroid cancer where you can see a hypoechoic node. Remember, this is a normal thyroid. The surrounding is a normal thyroid, which is the normal gland, which is hyperechoic. And amidst that, you are seeing a hypoechoic lesion. So this is the lesion, hypoechoic lesion, and you are seeing some microcalcifications also inside. And you can also see that this patient's nodule's height is actually more than width, which means it's more taller than wider. So almost every single feature of high risk nature is there. So definitely this is likely to be a malignancy. If this is present, surely I'll be taking this patient for a FNAC for sure. There's no doubt about that. Based on FNA results, I'm going to treat this patient. Okay. Now, how will you overall approach a thyroid disorder. Suppose if you're having a suspected thyroid disorder, you have to know whether it's a functional problem that is what you are suspecting, or if it's an anatomical problem you are suspecting. Anatomical problem usually comes in favor of a solitary thyroid nodule or a multiple nodules. Multiple nodules usually don't go towards a malignancy, and that's something different. We are not going to worry about that. Solitary thyroid nodule is what you're going to worry about that. In this scenario, you're going to do a TSH or a full TFT as a first investigation. Based on the TSH, you know how to categorize whether it's decreased or whether it is normal or increased. If it's normal or increased, you will ask yourself whether is there any indication for FNAC is there or not. If there is no indication, then just observe the patient. If there is an indication for FNA, then you have to go for FNAC. Based on the FNA results, Bethesda classification system, you can treat the patient. If it's decreased, then do a radioactive iodine uptake. If you are finding a hot nodule, which means it's very likely to be benign because the risk of malignancy in the presence of a hot nodule is less than 1%. If it's warm or a cold nodule, it's better to consider FNA if there are indications. So this is how we are going to evaluate a solitary thyroid nodule. Then if you suspect a functional problem like a hypo or hyperthyroidism, again do a TSH first. So when you do a TSH, there are three possibilities are there. It could be low, TSH could be suppressed, or TSH levels could be increased, or TSH levels could be normal. Clear? So if the TSH levels are low, the next step is to see for the T4. And even if TSH levels are increased, again look for the T4. If T4 levels are low, T4 levels are increased, and T4 levels are normal. Remember, in the presence of low TSH, if you have a high T4, definitely it goes towards a primary hyperthyroidism, and it's an overt primary hyperthyroidism. Fine. In this condition, the next step that you're going to do is relatively fairly simple and straightforward. You're going to do a radioactive iodine uptake. That's all. That's the next step. There's no doubt about that. And again, you will classify as increased uptake or decreased uptake. If it's increased uptake, usually it goes towards either Graves, we are going to have a diffuse increased uptake in scintigraphy, or it could be a toxic MNG, where it will be a multifocal increased uptake, or it could be a solitary toxic nodule, where we are going to have a focal increased uptake. If you have a reduced uptake, now see the thyroglobulin values. If thyroglobulin values are decreased or thyroglobulin values are increased. If thyroglobulin values are decreased, it goes towards the thyrotoxicosis factitia. But for all practical purposes, you have to consider whenever radioactive iodine uptake is decreased in a primary hyperthyroidism, always think about a thyroiditis, destructive thyroiditis, like D. curvens or even Hashimoto's can produce this picture. Remember, Hashimoto's rarely only will produce Graves-like picture, but commonly they will produce low uptake-like picture only. Be careful. And they can also, you can also get this kind of result in a patient who is having struma ovary. Obviously, a simple ultrasound is going to tell you where is the problem. And even uptake scans will tell you there is uptake in the ovarian region. That's a struma ovary. So it's very easy to differentiate all these conditions. Suppose if you are having a reduced T4 in the presence of a low TSH, you have a reduced T4 means both are going in the same direction, which means you are dealing with a secondary or a central hypothyroidism. Secondary or a central hypothyroidism, which means you are actually dealing with a pituitary insufficiency. Patients may have other problems related to pituitary insufficiency like adrenal insufficiency and hypocortisolism also. Be careful about that. So patient is having a pituitary insufficiency here. Patient is having a low TSH but a normal T4. What does it mean? Which means the T4 is inappropriately suppressed because the T4 is coming in excess if the TSH is normal. So which means it's a primary hyperthyroidism only, but it's subclinical. It's a subclinical primary hyperthyroidism. That's all. It's simply called a subclinical hyperthyroidism. Okay. Then TSH now is increased and T4 is decreased, or T4 is increased as well and T4 is normal. So if TSH is increased and T4 is decreased, means you are dealing with a primary overt hypothyroidism, no brainer, isn't it? So you're dealing with the hypothyroidism only. Very easy and simple cause. Suppose if you are having a increased T4 with increased TSH, means it's again a no brainer. You are dealing with a secondary or a central hyperthyroidism. This picture itself is very rare, or probably you are dealing with a pituitary thyroid hormone resistance because of TR beta mutations. I told you there also in TR beta mutations also you will be resulting in hyperthyroidism like picture. I have discussed extensively in the physiology section. So this again is a very rare picture. Why? Because among all the pituitary adenomas, usually it's a central hyperthyroidism, means you are thinking about a pituitary adenoma only, thyroid trough adenoma that is producing excessive TSH and excessive T4. But generally very rare, you don't get it, because among all the pituitary adenomas, the least common, the rarest is thyroid trough adenoma only. Go back to your pituitary adenoma section and see, I would have mentioned very clearly, less than 1% incidence. If you are going to have a normal T4 with a high TSH, means the TSH is inappropriately elevated, means that high TSH is needed for the gland to produce a normal T4, means it's a lazy gland. Again, it's a primary problem only, it's a primary hypothyroidism. In this condition, we are going to call it as a subclinical hypothyroidism. That's all. Suppose what will you do if the TSH is normal? Remember, if the TSH is normal, still you cannot rule out certain disorders. Like you have to think about some other disorders like central causes. Still central causes could be possible. Remember, in central causes, if TSH is normal and you have a low T3 and low T4, think about a central hypothyroidism. You cannot rule out. If you have a high T4 with a normal TSH, think about a central hyperthyroidism. Clear? Suppose if T4 is also normal, T4 is not having a problem, look at the T3. If T3 is decreased or T3 is increased, if T3 is decreased, you can diagnose a low T3 syndrome or a CQ thyroid state in this condition. TSH is normal, T4 is also normal, you're having only low T3, think about CQ thyroid state. Remember, even though in severely sick cases and in patients who are having late stages of CQ syndrome, TSH and T4 may also be dropping, but in early stages at least, T4 and TSH will be normal only. So if T3 is increased and T4, TSH, all these things are normal, you can even think about a isolated T3 toxicosis. Very, very rare. Suppose only if your clinical picture is correlating with this, diagnose these disorders. It's very, very rare disorders. So don't diagnose straight away in your clinical picture. So only if your clinical features are correlating with your investigatory findings, then you can diagnose these disorders, isolated T3 toxicosis. So this is how you are going to evaluate a thyroid disorder. Clear? So this is how you have to know, this is how you have to approach a patient with a thyroid problem. So with this, I think I have made your workup very, very simple and in a very easier way. I think we can conclude this video with this and we can move on to the next section on thyroid malignancies.